Good afternoon. Is that one working? It's
Hello.
hello. It's working now. We will
Hello.
use this one. That's fine. Good afternoon, everyone. I hope you're enjoying this day as much as we are, and that so far you have learned a lot of new things or discussed new things and met new people or met old friends. During this last session of today, for this session, I have the privilege to introduce to you Dr. Roberta Lamti. She's a family medicine physician specialized in diabetes. And not just a doctor, not just a researcher, but a strong advocate for education, awareness, and making people healthier by working with people to help them understand what's happening. Today we will talk about a very recent publication that you cannot, is it better this way? I'm not sure how, can you increase the volume? Apparently I'm not sufficiently audible in the back. Is it better? It's better, I think. Okay. So we're going to talk about what happens after pregnancy. 2 months ago, a publication I'm actually really proud of came out with recommendations about long-term care for women. We know women with hypertensive disorders have an increased risk for what? I know you know this. For what are women with hypertensive disorders during pregnancy at risk of later in their life? Stroke, cardiovascular diseases, other diseases, kidney diseases, exactly. And this is what we're going to discuss. So this will be based on the work that was published about 2 months ago in Global Heart, and it was a collaboration with experts from Ghana in family medicine, obstetrician gynecologists, researchers from the Netherlands, Nigeria, and Tanzania. The details will be discussed and shared to you by Dr. Lamti, but you're on cutting edge science. There's also many things we don't know yet, so that's where we're actually looking at you to think along with us. But without further ado, let me give the floor to you. Welcome.
Thank you so much, Joyce, for the kind introduction, and thank you all for being here. Really appreciate that you are here and you have this much interest. I'm going to try and make it as interactive as possible. Is it possible to get a slide changer, please? Or you're going to be moving it for me? How are we going to do it? Can I change my slides? You will do the movement? Yes, please. So, yeah, you can run the slides, please. So my name is Dr. Roberta Lamte. Please call me Robbie. She said a lot of things about me, but I'm also a mother. I've gone through pregnancy before. So beyond my experiences of what happens after pregnancy, I'm sitting in the consulting room and I'm thinking, too much water under the bridge. I mean, so hopefully these guidelines will help us. Is it possible for you to run my slide, please? So, as Dr. Brown said, we published this recently in Global Heart, and I'm presenting this on behalf of all the collaborators that you see there. It was a lot of arguments, a lot of back and forth, because we really wanted it to be get up and go recommendations. We didn't want it to stay on the shelf. And that's why we thank you so much for being here today. And we hope that after today, it's open access. You pull it up and say, let's make this happen for our women. Next slide, please. So, like the pregnant woman you can see there, I know you've seen her several times today. I like the statement that says, events to come, what do? That's why we are showing you that shadow. It's not for nothing. So we are saying when you see the woman, when she's pregnant, she has GDM, she has hypertensive disorders in pregnancy, it's casting a shadow 6 years ahead of time. Please don't wait till 6 years down the line. She comes to see me and I'm like, oh, you have diabetes. But not only do you have diabetes, you've also gone blind already. We don't want that. And that's actually why we try to adapt these guidelines to our setting. We don't want no highfalutin things. Things we can actually take and run with. So events to come cast their shadows ahead. Next slide. Our focus was on prevention by screening. Because without a diagnosis, next slide, there's no opportunity to prevent. Without a diagnosis, there is no opportunity to prevent. And cardiometabolic conditions are largely asymptomatic. The patient feels very well. They go to work, and then at work they fall down. That stroke didn't happen that time? No. That stroke has been brewing for 10 years before. The woman wakes up, like the patient I saw yesterday, and she said, this eye is not seeing well. That central retinal artery occlusion is not today. Those risk factors started. So what our focus was on is on prevention. And our focus was on screening. Screening to be able to diagnose and then prevent. Don't want the women to come with symptoms by which time it is too late. Next slide. So we picked guidelines and we adapted it. As I'm saying, we wanted it to be put to use guidelines. Please help me. We don't want it to be on the library. Somebody will be citing me in China. I beg you. I want it to be used in my community. Whether you cite me or not, I don't mind. We want it to be put to use guidelines. And therefore, we went as far as we can to make sure that they are well adapted to low middle income countries. And it was consensus based. Next slide, please. We had 2 rounds of Delphi. So we had multi-stakeholder engagements of experts. People who all they do is see pregnant women. We had people who all they do is see diabetes. Experts in their field, well recognized in low middle income settings. Because they are the best people who will tell us what will work in their setting. And they came up with these consensus recommendations. I wasn't part of them, so don't say you push your way through. It's not me. I wasn't even part of it. I was just part of piloting. Doesn't make sense. But we had experts in low middle income settings, and these were the recommendations that they made. So this is the methodology. We looked at other guidelines from other places. What had been published? It was a systematic review. So we only limited it by date. We didn't even limit it by country. We pulled up everything. We had a protocol, registered it so that you can actually replicate our methodology. We wanted to be sure that scientifically we were crossing all the T's and dotting the I's. Next slide. So these were our results. But in summary, we pulled up 54 articles that met our criteria, and after together with 9 guidelines. So we had a total of 63 articles and publications with which to work with. And at the end of the day, we settled on, the experts settled on 33 final publications. And these were the domains within which the recommendations fell. So the first domain was identification. How do you identify a woman who has hypertensive disorder in pregnancy? Because if you can't even identify the one who is likely to be at risk down the line, then there's something wrong. So we wanted to be sure that everybody knew how to identify these special women. Then the next domain was, okay, you've identified the women, the at risk, the increased risk. When are you going to deliver that first counseling? When are you going to sort of say, open their eyes and say, my sister, my mother, my aunt, this is what the science is telling us. This is the category you are going. When are you going to time that first counseling? That's the second domain. The third domain was, what is the structure and in what setting are you going to deliver your counseling session? And your counseling session, what should go into it? What does the woman need to understand and know? Are you going to talk about waist circumference, BMI, exercise? What does she need to know? What should go into your counseling? And beyond the talking and the counseling, are you going to use any biomarkers to help you monitor? Is she getting better? Is she getting worse? Is the risk reducing? Is the risk increasing? What biomarkers are you going to use? And after identifying the biomarkers, after identifying that maybe it is systolic blood pressure, it is LDL cholesterol, it is HDL, after identifying, what cutoff do you use? Are you going to use a fasting plasma glucose of 5.6, or will you use 6.1? What cutoff value are you going to use, which will work in low middle income setting to stop the menace? I'm sure you all agree with me. It is unfortunate for diseases and conditions which are largely preventable, diseases which can cause havoc, not only for the woman, but for everybody else that depends on her. That daughter who could go to medical school, whose ambitions may be thwarted because the mother got a stroke, because the mother had diabetes and didn't know. Something that cast the shadow 6 good years ahead of time. That's what we are talking about. What threshold will you use to say, no, this thing we are playing with fire? One of my favorite students tell me that, now, what trap, be careful. Your trap, be careful. At what point are you going to say, your trap, be careful? Next slide, please. Next slide. Yep. Sorry, I thought I was going to roll it myself. So, what were these recommendations, which I'm sure you're all very eager? As soon as we leave here, you Google Lamte Brown, recommendations will come up. You go and show it to your management, say, this one, please, quickly, let's disseminate it and start using it. Because Dr. Lamte, Yatra, be careful. Enough is enough. It is not fair to our women. It is not fair. At the time they make and put in the effort, we will see change. That's when we want to put in the change. I don't want to be sitting in my consulting 6 years down the line and the woman will ask me, like she did yesterday, Enti meni na ebeye ye. I don't want to have to answer that question. I don't want to have to tell her I'm sorry, but you've lost the eye. You still need to change your diet. You still need to make certain difficult changes, but sorry, you've lost that eye. We don't want to wait until bothersome complications set in and force the population to change. Because when it is asymptomatic, that's when they make the difference, they make the change, they put in the effort. We talk to them in a way that they can understand. Communicate the risk very well. Communicate it very well. Because we all know that don't do this, don't do that. As for that one there, doesn't work. Please, does it work? Who here will not eat that white rice that Joyce and her organizers have packed for you? I wasn't here at lunch, but I know there was pie. Who didn't eat some? You see, oh, so please, as for the don't do this and we don't want that. It doesn't work. We want things that will work, because we are talking about serious situations. Very, 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 very serious conditions. And we want to communicate it in such a way that the women will take it themselves and run with it. No sugar reading is bad. No weight on the scale is bad. No BMI is bad. It is all a learning curve. It is a learning process. So today, your weight is this. Tomorrow, it will be something else. We want to get the women to appreciate that it is a learning curve, a learning process, and they can do it. Next slide. So what are these recommendations, which I'm very confident everybody here is going to download? Show me your wave of hands. Yay! And we are going to implement. So the first one, the first domain was on identifying these women. Identifying our women. And now we are career women. We are going into pregnancy in our advanced years. We are already going into pregnancy with carrying our baggage. We've selected our exposures. Time varying exposures is what we've exposed ourselves. Now the pregnancy is also another exposure. So how do we identify these women? First slide, please. So the recommendation is very simple. It is either chronic hypertension, or it is gestational hypertension, or it is preeclampsia. No libi, no laba. It's only 3. Identify all these women. Is it chronic hypertension? Is it gestational hypertension? Or is it preeclampsia? And how do you decide? Next slide. So, it is all about within or after or before. So, if it is within the first 20 weeks of the index pregnancy that you are making the diagnosis of hypertension, then it is chronic hypertension. Within the first 20 weeks, I know that in our setting, you may not see them within that first 20 weeks. But if you have the privilege, the woman is booking at 13 weeks, and you are seeing and diagnosing onset of hypertension at that time, it is gestational, it is chronic hypertension. Next slide. If it's after 20 weeks, you don't stop there. You've been managing the woman first trimester, blood pressures have been acceptable. 20 weeks now you see hypertension. You need to find out, is there proteinuria? But not only proteinuria, are there hematological abnormalities? Are you seeing help? So that is what, next slide, makes the difference between gestational and preeclampsia. So you see end or evidence of any of these things, changes in the biochemical parameters, even though it is starting after 20 weeks, I beg you, reclassify upwards. And it may not be this in the biological parameters. You look for proteinuria, well dodge, it's not there. But you see that the baby is not going well. It's kidney dysfunction, IUGR. When you see that, reclassify the woman. Reclassify her higher to preeclampsia. Next slide. So now we have identified the women. You see the woman, it is very clear. You can classify her. She is an at-risk woman. Watra, be careful. She has crossed that line. So you have to have strategy. You are going to communicate to her. When should you do this first counseling? Next slide. With the diagnosis of the condition is the best time. It's a window of opportunity. It's the best time. Because you want to give her the best chance. You don't want to wait any longer. So when you make the diagnosis, that is the best time. If you miss that time, then either in the immediate postpartum or at another time during the pregnancy, when you miss when she comes for the postpartum review. But the one I've put there is the best time. So as we train our people to be able to identify, we also train them to identify and counsel. Next slide. So where should this counseling happen? In what setting? Next slide, please. So what we want to say is that it should be in a place that is accessible to the woman. It should be in a place, don't say that, as for this thing, I can't say it, you need clinical psychologists. Travel from Kojo Krom to Tamale. Please, we beg you. This is no clinical psychologist counseling matter. Don't say that you need obstetrics specialists. We don't have some here, so we won't do the counseling. The setting should be where the woman can assess it. Because this is potentially life-changing. Not only for the woman herself, for her index pregnancy, her future pregnancies, and everybody else that depends on her. Yes, in an ideal situation, if you can get it, why not? Multidisciplinary. Excellent. Very good. But if you can't get it, please, whatever is accessible, regardless of speciality, please help us do that first counseling in that session. Obstetricians, midwives, maternity care should make it a routine so that it's not special. It's routine. It's part of care. When you pick up somebody in these three categories, chronic hypertension, gestational hypertension, preeclampsia, automatically routine kicks in. You will be able to communicate that increased risk. You see, my clinic where I work, there's one thing them for. There's one thing. We don't have a lot of things correct. But as for one thing, my clinic, when you come, you say, doctor, today there's nothing wrong. First time you are coming there, they will check sugar. You say, doctor, today I have diarrhea. They will check your sugar. You come, you say, today there's nothing wrong with me. They will check your sugar. I don't know whether it is because they want to pick the people up or because we charge money. But I want to believe it's because we want to pick the people up. You get it? It's routine. When you come, you say, my leg, I have accident. they will check your sugar. You say, there's nothing wrong with me. We will check your sugar and collect your money. But we are picking the people too. So please, I'm not saying that we do that because of the money. But what I'm saying is that make it a routine. Oh, you have hypertension in pregnancy. You have preeclampsia. You have gestation. You will get some counseling on your risk. You will understand what it means for you now and for the future. Next slide, please. So, best practice, because we know there are places that can achieve this best practice. So we didn't want to leave that out of the recommendations. And now generally most facilities are using EMRs. So we thought that that was a good place to capture the data and to utilize it in our counseling. We also thought that it is important that what is happening now is got to stop. It's really got to stop. I don't want to see a woman 6 years down the line and said, I had that stillbirth. My baby was very big. Nobody told me that it was diabetes. It has to stop. And the reason we are losing them, they are falling out, is because there's no transition. Obstetricians, gynecologists are managing pregnancy. Internists, physicians, general practitioners, which we are managing hypertension, CKD. There's nothing for the woman in between. So we thought that that transition is actually our window of opportunity. Why is it a window? Because it can close. It can close. And unfortunately, this window, when it closes, it's closed forever. So when the window is open, we want to take it. Because most of these conditions, they are aggressive. They are aggressive. And we think that the recommendations suggest that if it is possible, let's have a transition of care. She's leaving OBGY. Let's not just leave her. Let's have a transition phase before she ends up in adult care. And take advantage of the window of opportunity to do primary prevention. By the time she comes 6 years down the line, she's asking me, Doctor, you understand? Complications like retinopathy, they actually start 5 to 6 years before people even meet diagnostic criteria for diabetes. That time is gone. The woman is asking you, will I see again? So what we are saying is that let's take advantage to do primary prevention wherever possible. We formulate a guideline to ensure continuity of these women. Next slide. We said all maternal centers, OBGY facilities. So we know the traditional ones, the ones that we can close our eyes and rattle. Adiposity, central adiposity, blood pressure, proteinuria. But I'm sure today we have learned that there are non-traditional cardiovascular risk factors. They are risk factors, very real. Gestational diabetes. I told you, when you don't see the proteinuria, you see IUGR. It's a risk factor. When you follow the women up, you see that they were at increased risk. So it's good to know the traditional established risk factors. But once we are taking care of women, OBGY women, IUGR, preterm delivery, gestational diabetes, they are risk factors. So if you pick up these things, you want to be able to follow the woman, but you want to document that, oh, at this time, I assessed your risk and it was this. And communicate it to the woman. But it also helps you to have a life course approach, because it has implications for the woman and for the index pregnancy. Next slide, please. Yeah. So in as much as we've spoken a lot, we say pick up and go, some training will be required. And it's not difficult to find or achieve. Very easy. Lots of resources, people available. So training so people can connect the dots. Say, but this is hypertension. In what way does it connect to sugar? The fact that my baby is small. Me, I'm small. Oh. Me, I'm nipa kitwa. So people can connect the dots. That there's a link between hypertensive disorders in pregnancy, prediabetes, diabetes, dysglycemia, IUGR, kidney disease. So with training, it becomes clearer. With training, we are able to offer balanced communication. So yes, you want to remain positive, you want to hear the woman's side, but I think too often as doctors and healthcare practitioners, we don't let the women appreciate what can happen if they do not adhere. They don't appreciate it. We fail to communicate that. So we think that it's an important part. Next slide, please. So what are the information needs of these women? When you pick them up, one can cry. Even when you summarize the things that must be in that counseling session, the things which you must communicate, and communicate well. You know how the emergency physicians do it? Give adrenaline, whatever. And then the other person says, adrenaline this going. So you are communicating well. Say, give adrenaline. The person says, normal saline going. You said, no. You get it. So what are the things we should tell our women? Next slide. So they should be informed. The woman should understand that, it's not cha-cha. This is not 50-50. We have seen many women like you with these kind of parameters. It is more than 50-50. And it is not due to chance. You see, if something is due to chance, then you can't predict. But if it is not due to chance, the probability, you can predict it. We need to be able to communicate increased risk to the person. Say, this one is not a case. This is a straight line. If I put one step here, I put the next step here, where will the next step be? They'll say here. You say, hey, are you prophets? Say, you have predicted the future. It's on a straight line. Y square to mx plus z. You know the slope, you know where the next step is coming to be. The woman needs to understand that she is at increased risk. Based on the historical data, because this is not due to chance, we can predict it. You want to communicate in a way, the probability, a way that they can understand. And I believe we can all do that. Not so? Thank you. Next slide. And we want to emphasize that. I know it's difficult. Practice what I preach. So people don't like to eat near me. Some people, they don't practice what they preach. But it's fact. The first step, in fact, the most efficacious, is making those lifestyle recommendations. And it takes a whole lot to just take a pill, that now decide, I'm coming to Joyce's program. Would there be no low sugar, no fried? Will she remember that she has to give me vegetables? Is there pesticide? Is it organic? It's far easier not to, let me just take some diuretic and come and eat the sodium-laden food. It takes effort, but it's very, very, very efficacious. And we must learn. You know, they say, who is a leader? The leader knows the way, shows the way, and that's what? Goes the way. How many of us are going to go the way? I'm going to watch that lunch dish. So we want the woman to understand that the first approach to substantially reduce this risk later on in life. You know, the reason why I'm so passionate about it, the obstetrician see what I'm seeing. Oh, me, I'm a primary care physician. I am the woman who come and ask me, like she told me just yesterday. Oh, she said, "Enti menino ebeye my eyes, can I see again?" She won't go and ask that obstetrician. Oh, she won't. It's me. And then me, I have to break the bad news. And then they'll cry in my consulting room. Now yet, the obstetrician is somewhere. Me, I'm seeing something. Oh, the thing I'm seeing is not easy. I'm seeing the leg in the rubber bag. The black rubber bag. When you see a leg in the black rubber, do you know what it is? I'm sure obstetricians, they don't know. Leg in black rubber bag. So please, you are seeing the women when it can make a difference. Help us. Make it a little easier for us 6 years down the line. Don't let me finish talking to the woman and say, so how come nobody told me this? And you are now telling me, after you have cut off my leg, you are now telling me I've been going to the hospital. So we are saying that because of later in life, please, I beg you, I'm on my knees, because what I am seeing is not easy. You people, when you are seeing them, they are young, they are born in life. Me, I'm seeing them post-menopause. Do you know that diabetes increases your risk for all-cause cancer? I'm seeing them. Breast cancer, mastectomy, blindness. What is this? Please, will you use our guidelines for us? Thank you very much. Next slide. For the later in life, I beg you. Now, what is the recommended minutes you have to exercise? You see how you are rattling it? Now lie now. As for the 30 minutes, it's minimum. That one is if you want to manage. But here, we are talking about primary prevention. You are looking close to 5 hours in a week. Yes, so please, the 30 minutes, look at it. Please, what is this? I can't hear. What is it? At least, it's not the maximum. I don't understand. You ask somebody how many hours I say, I meet the 30 minutes recommend. What is that? The sign is less than. Minimum. Please, minimum. So please, tell them that for this condition, if you are able to go beyond the minimum, please go. Because the benefits are far more. In fact, if you are thinking about driving diabetes into remission, it's not 30 minutes, please, it's strength, flexibility, plus aerobics. Now go so. Go so the ding. Yes, when you are coming, you come prepared. You see my bag. My lunch is always inside, because by the time I'll go and get there, I say, do you have fruit? They say, no, we don't have fruit. We have Coke. Hey, next slide. I don't want trouble. I go prepared. In fact, some places, they don't even have water. Please, let's clap for Joyce. Ask for water, dear. Ask for water, dear. But some places, there's no water. They are high-tech. Ginger, kiwi, carrot, this. Water. Oh, no water, but we have this. Next slide. So screening. How do we screen? What biomarkers are we going to use? The simplest ones. The simplest ones. We are in low middle income countries. Of course, if you have more, why not? Because we don't want you to say, oh, me, I don't have this, oh, apolipoprotein B. A B need the whole region, a B need ho. We didn't put that. We said blood pressure. Simple one. As for sphig, dear. Sphig, dear. Chips cry, you will be wo. I didn't put apolipoprotein B, oh. Sphig, dear. A B wo. BMI. Simple one. Not so weight and height. This one, I'll add my own. I told you this one is the expert panel that wrote it all. But I was very happy because they were writing what I wanted to hear. Only the one I wanted to push in, it didn't come. Tape measure. Waist circumference. It's more powerful than BMI. So you may not have skill. As for tape measure, dear. Cheap. It correlates with your lipid profile. Good marker of adiposity. Somebody will tell you, oh, me, my own is muscles. It's bones. There's no bone here. Here, bone. There's no bone. So when tape measure says it's red, you can't tell me it's bone. If I do BMI, I say my bones are heavy. Some of us, our bones are heavy. But the panel said BMI, so it's just BMI. But tape measure too, it's very good. Now, fasting blood sugar. Easy one. Okay, next slide. And we say that if possible, wherever possible, you know, the woman, she's only one. Don't break her up into hypertension clinic and GDM clinic. Integrate the care. Don't let her come postpartum clinic. Integrate her care. Integrate these things so that when she is coming, the lorry fare is only one. She doesn't have to come for a screening and then come for postpartum visits, postnatal. It's too much. The woman, she's only one. So please, let's integrate the care and make it easier on the women. Next slide. And then there are these other ones. Those of us in Accra, we have access to it. It's good. LDL, cholesterol, triglycerides, and again, integrate when you do it so that she's coming to the hospital and she'll get it done at once. Next slide. I've spoken a lot. I trust that you will use our recommendations. So this one I won't talk. Please read it as it is for me. Let's go together. Please, what is that word? Reassessed. We beg you. You are not doing it. So I'm sitting my somewhere. I wasn't there 6 years ago. I wasn't part of the OBGY team. Then the woman will come and ask me, will I see you again? If I say no, she starts crying. Meanwhile, I wasn't there. So please, reassess them. It's better to reassess them 6 months rather than I will now reassess at 6 years. Eya home te. Munkabi maye. We beg you. Women, let's go on. I beg you. This one, Watra, be careful. So if it means she has to travel from Kumasi to Tamale, because the body is telling you something. And we know that certain levels of albuminuria are potentially reversible. This one, when it gets to this stage, we have to find that specialist to guide us. when we reassess and it's going on, it's not getting better, we need that specialist input. Next slide, please. Otherwise, we can use our primary care providers if the markers are within normal. If other markers suggesting that they need a cardiologist, you want to do that. But if you assess and everything is fine, don't leave them. Because once the person is at increased risk, the body has shown you what it can do. The person needs to understand for the rest of your life, you need to be monitored at least annually to be sure that things are not changing. Next slide. So we have identified the woman, we have spoken to her, we've checked her biomarkers, we've counseled her. But at what level, what are the cutoffs that we should be using to let us know that this one, well, try to be careful. Let's look at those cutoffs. Next slide. Please, what is normal BMI? You see, she's got it wrong. Okay, less than. The equal to no. Yedi sheho keke. So I beg you, 25.1. I'm sure your scale can't measure 25.1. So when you see the 25, put your antennas up. Because there are some studies that have shown that in black people, actually, increased risk is BMI of 23. And to me, cry me the borderline. Ayaka. So please, so less than, equal to no. Equal to no, say, we are 25.1. In fact, 0.00001. Your antennas have to start going up. And there are studies which have suggested, especially in diabetes, that for black people, increased risk actually starts from a BMI of 23. For the Asians, they've published plenty. I'm sure you know the Asians is 23, but Africans also. So please, so this 25, when you see it, ask yourself, is it 25.001? Both women and their caregivers. Because you know, sometimes it's the mother-in-law that will be giving the palm nut soup. It's the mother-in-law. She doesn't know about saturated fats. And that it is the primary driver of LDL cholesterol. The substrate for cardiometabolic disorders. So you educate the woman and her caregiver, her support system, about these numbers. And we are talking about HDL cholesterol of higher than 1.2 and triglycerides below 1.7. Let me hasten to add that you don't want to check this in the postpartum period, because there are some lipid derangements we go along with pregnancy and the postpartum period. Please, what is normal blood pressure? I'm sure you guess where I'm going with this. What is normal blood pressure? Yes, my dear. Excellent. Winnie, my dear. You get a drift. Don't check a blood pressure of 120 and 80 and say, it's okay, madam, go home. There's nothing wrong with you. It is not normal. It is not normal. Normal blood pressures are below 120. And so maybe the diastolic is 110. The systolic is 110. The diastolic is 80. It's not normal. I beg you. It is not normal. Don't say, yeah. Oh, or see pressure net is saying, oh, yeah. Meanwhile, the pressure is 120 and 80. And yet, put her antennas up. The Americans are telling us that to diagnose hypertension in a non-pregnant woman, use 130 and or 80. It is hypertension, not pre-hypertension. No, I beg you. Next, please. What's our fasting sugar? What is the normal? You get the trend now. So what is normal fasting blood glucose? Normal. Yes. I can't hear you. Hello? What is it? Below. Please clap for madam for me. Below. So 5.6 is not normal. It represents an increased risk. It is not normal. Don't check it and say, oh, sugar ended there, yo. A 5.6 per chop. Increased risk. That is when we start talking about the contomere, the lefu, the ayoyo, the ademe, the okro, the garden egg. Please. Type 2 diabetes is a potentially reversible, potentially, depending on what you tell the patient. Next slide. Pacho. Manuasi.
Thank you. Who can I invite for questions? There must be questions. She has answered all your questions.
I want to commend her because typically or traditionally by doctor's training, you could see that the training is oriented towards the curative. I'm so impressed to see a doctor who is so passionate about health promotion. And then speaking about primary prevention, I could see some element of primordial prevention in your presentation. I think you deserve my salute. I'm not a military officer. I don't know how the women do it, but you deserve it. I've learned so much from this, and your appearance is a living testimony. At this point, I don't even know how old you are. And I know it's unethical to ask for your age in public. But backstage, I'll ask you because you really inspire some of us. Thank you.
Do you have a question for the audience?
Yes,
I figured.
yes, please. Maybe he's...
So, Dr. Lamte, thank you so very much for such a wonderful presentation. I can sense the passion in the presentation. Unfortunately, I belong to that group who has been punishing you a bit. And truth be told, the transition, as you rightly pointed out, is where the gap is. I don't know. Is there any recommendation going forward as to how that transition can be made very smooth for the clients? I think it's just last week thereabouts that in my facility, the public health, the head of institutional public health unit called me and told me that they don't have work to do in their unit. So what they have offered to do for us is that every case of preeclampsia that will be discharged from the hospital, they want the name, address, and phone number. They will follow up to the house, assist the patient with home BP monitoring, and the follow-up during. So I was like, that's nice. You know, yes. So the transition, I think maybe we should look at ways of proposing solutions to bridge that gap. And then I think we can help our women. Yeah, thank you.
Thank you so much. So I think that's a wonderful example to take forward. The only thing I would add is, you know your setting best. Put the call out. Say, today I came here, some woman came to cry that the things we are doing, some people somewhere 6 years are suffering. So this is the problem. Let's put our heads together. What can we do? And I believe wonderful ideas will come up. I did some training somewhere. I said, hey, you need to see the postpartum sugars. Somebody from Tamale. I could never have thought about this. They came back later on. They said, when we went and we told our people, do you know what they did? They bought one glucometer. Everybody bought their strips. So they go around. They got post-meal sugars. They say, hey, so we eat the banku. It goes from 6 to 20. Hey! When we eat dale, who is this? Only one glucometer, one community. They had post-meal. They made a change. So 2 heads are always better than one. You know your problem best. What I will add is, I am a family physician by training. Gradually, we are increasing in numbers. If you can get one, rub them in. Say, please, don't wait 6 years. So if you wait 6 years, you will cry pepper. You better come and join us here in this clinic, multidisciplinary. That public health person say, oh, don't worry. When they discharge them, we will give you the details. But now we have diagnosed them. Come and help us here. So that is what I will add. Thank you very much.
I saw a question in the back, then I'm coming.
Thank you very much for a wonderful presentation. I think there was an aspect about the monitoring at 6 to 8 weeks. Okay, you made a point about persistent proteinuria, or let's say deranged EGFR. Okay, but I didn't understand when to refer to see the nephrologist. Is it at 6 to 8 weeks, or when they come back in 3 months' time? Thank you.
Of course. Thank you so much for the question. So my recommendation would after the postpartum period, because you know within the postpartum period you may have some derangements in your lipid and all that, but after that period and it is persisting, you need to make that referral. The additional thing I would add, it depends on how high, how far away from normal you are. It also depends on your assessment of adherence of the woman to your recommendation. If you think that if I'm to wait after 8 weeks, she won't come back, please refer her at the 6 weeks. If you think that if you refer her at 6 weeks, it will take her another 6 months to gather the money, don't wait. So assess the situation, because what we are saying is that that persistent proteinuria could be indicative of more serious underlying renal conditions. And the earlier we initiate changes, initiate follow-up, intensify the education for the woman. Sometimes it's not just about the kidney. You know, as black people, generally we are salt sensitive. So those other little things all make a difference. So that would be my recommendation. Thank you so much.
Thank you so much, Doctor. I'm highly educated as I've been here. Thank you so much. Mine is just an add-on to the whole thing, speech you gave. I am thinking about the socio-cultural and then the socio-religious elements. It's beautiful to actually teach them everything, counsel them and everything. But we know as Ghanaians, we are very highly religious and highly cultural. And at times you will tell this person, you won't see them again. They will go to other health institutions. And the problem is you have one pregnant woman having about 3 antenatal books. So there is no continuity of care. So we have to look at that aspect too. I think it's a big problem. It's been resolved with the use of the electronic records, but we know that it's not every facility that has it. So they run from one unit to another, and then by the time you realize, they come in with complications. So thank you very much.
Sure. In fact, it's an excellent point you make. And we do a lot of self-management education. And it's proven fact that the more you talk, the less effective you are. The more you talk, you know, I told you that don't do this. It doesn't work. See the man. Look at it. It doesn't work. So why are you talking? The more you talk, it doesn't work. So you want the patient to talk. Empower them. Hear them. Let them understand that, oh, okay, you can believe in your Tigari or Hail Mary. However, within the limits of science, this is what we know. You can put it together. Kaboom! It's better than leave yours and take mine. Hear them, empower them, offer suggestions. Person comes, they say, no, maybe it's your way. No problem. Give them short follow-up period. So instead of letting them go for 3 months, oh, please come in 1 month. Re-offer. Understand their context. Find a way. That's all I will say. Find a way. Because this is not bad news. It's just serious news. Very, very, very serious news. You want to communicate it in such a way that the patient gets it. The patient is not the one who is failing. It is your responsibility to keep offering, to keep changing the way you present the message until they get it. You see how I've presented it to you? Another day I would have come very, very professorial. Show you. I've learned the hard way. So you also have to learn the hard way. You present it like this, it doesn't work. You go back, you reflect. It's okay, next time. Me, I wear high halo. You see my bag? I have kambu. I've learned that if I'm going, my things and kambu, 0. So please, today I'm looking nice. You take me seriously.
Thank you. I think I also have same in my bag. And when I want to stand in front of people, I have the high heel. Yes. Thank you. When you were speaking about the values, like the BMI, you made mention that for other areas, they do researches. And for Africa, studies have shown that ours should be 23 or less. You being a researcher, I would want to find out from you, when you were speaking about the identification for the women, the classification, and you said preeclampsia, the chronic one, gestational, and then preeclampsia. Is it possible to do further studies to know when the onset of the onset of preeclampsia in African women? Because I was, some time ago, something happened to me. I said it in the other class. As early as 12 weeks, I was having all the signs of preeclampsia. The swelling, the proteinuria, and the vision issue, epigastric pain, severe headache, high BP. I don't know. I don't know what it was, but it was very early. And because of that, they had to do so many investigations at the time, which was very expensive, because I remember keeping my urine in the fridge for 24 hours, and they would take it to South Africa. Yes, but it was too early, and they used me for case study. Yes, because they said it wasn't 20 weeks. But I know that some doctors at the peripheries, or people who are not specialists, will wait for people to get to 20 weeks before they diagnose preeclampsia. So you being a researcher, I think we can do more research into it to see the onset for black women.
Thank you so much. And I think that's very, very important. So we need to drive our own research. We need to try and get the funding for it. We need to get our government to appreciate. You can't just take something from Europe and come and dump it here. We need our own studies. I have had people send to me from ophthalmology. Say, Dr. Lamptey, we are seeing diabetic retinopathy, but the sugar is 5. I say, yes, because it's on a curve. There are people in the tails. So yes, and remember, you know, no level of sugar is okay. This glycemia can be associated with complications of diabetes. So I say, yes, it's diabetic retinopathy for sure. Okay, so very important point, very valid point, and we hope that we will get to the point where our policymakers will take the outputs of our research and actually drive it into policy. Thank you so much.
Thank you. And to add on the risks that African women may face, tomorrow Dr. Claire Simpson will give a presentation about a genetic risk. It's also linked to the spot studies because there are some signs that there might be an elevated risk, a higher risk for women from African descent. So tomorrow.
Okay, thank you so much. Doc, thank you so much for the wonderful and the nice and educative presentation. In fact, I will see you later. My boss, so I'll also follow her. You said ideas. Please, our lifestyle in the community. I'm a public health nurse, so when it comes to preventive, I really love it. Our lifestyle as health workers in the community also counts. We have sectors we like telling, but we don't practice. We can tell much about it, but as for us to practice, for them to follow, we will not do it. So we need to also practice in the community. And my sister said something that when you tell them, they will go and do the same thing. Yes, they will do the same thing. At times, evidence-based counts. We need to get some of the evidence and present it in the community. At that church or wherever, we present it for them to know. I normally do cervical screening education. And when you are talking to them about it, they won't take it. But when you present pictures, like local people experiencing it, they will take it. So our lifestyle also counts. And as doctor said, we also need to collaborate ourselves. Whatever in the hospital, whatever facility that we are, we need to engage everybody on the desk. Let them know this is what is going on so that everybody will know what to do at the end of the day. Thank you so much.
Dr. Lamte, thank you for the presentation. I'm actually a preeclampsia survivor, so for this topic, when I saw it, I really wanted to be here. Last 2 months, I had to go and see. I went to the eye clinic because I was having vision issues, and then I went, and then the doctor told me that, in fact, because of your BP issues, your sight is getting bad and bad, so you have to go fully bifocal from there, and then I had to change my lens and all of that. So it's one of the things that I'm very passionate about, especially something that you get after having such a severe condition. I remember I was on a radio station, okay, because we do that periodically. We were educating, and one man called in and told me that he doesn't understand why we tell their wives, that this is what can happen, and this is the side effect even later on. Because the man was saying that, he called me out and mentioned my name. You are this, right? Yes. My wife comes to your room, and she told me that you told her that there's a possibility that she might get stroke even later in life.
Yeah.
And now my wife is scared. Why do you have to scare my wife that she's pregnant? So, you see, we are at a point where I feel that we need to, I don't know how we can do that. We need to empower our women so that they can take ownership of their own health.
Yeah.
The few that get to understand and appreciate some of this, they take better care of themselves. They make good decisions. But the majority, it's like their lives are in the hands of men that don't understand a thing about what happens to the woman and her body, and all of this. But this is where we are. Another thing is, this is something very beautiful that we need everybody, on board. Are there any plans to get stakeholders involved so that we can push this thing at a national level, so that people get to appreciate some of these things. It is your future, whatever it is. So are there any plans? It is so sad that even now, in fact, the people that can make those decisions, they are not even here. It is we, the same health workers, that are going to practice, that are always going to complain, that are here. Are there plans so that some of these sessions, these parallel sessions, these stakeholders would be here? So that at least, if not here, are there plans to actually even educate them in their, I don't know how, but they need to hear this because they make those changes, they make those policies. Health promotion, health prevention is what we need. We don't need to be doing creative because it will be too late. Okay, thank you.
Yeah, thank you so much. So, the first point about women, you know, unfortunately, majority of our women are disadvantaged. They don't get the opportunity to go to school. Economically, the society, our society is very mean. Our society doesn't permit women to go beyond a certain ceiling. It's a man's world. And if you don't have that opportunity, you don't have the privilege of having the opportunity to have your own mindset of yours, understand that you don't need a man to be you. It's not easy. So these are very deep, ingrained issues which go beyond health, far beyond health. And that is why it takes us. We understand the context. You can understand that woman's context better than maybe Joyce. You know the community where she's coming from. What matters to her is that she has a child by all means. She must have a child. It's her third marriage. She must have a child for the man, even if it means dying. So the contextual and the cultural issues, but we can change it one woman at a time. We can. I believe that. It will take a while, but with persistence and efforts, we can. So we have started by getting it published, and we are thankful for that. So we'll take your feedback on board, work harder, and get the policymakers to hear us. But I have one question, hopefully. And I think.
Yes, okay, it's a contribution. I think through our discussions, we've gotten to the point where all of us are speaking a common language. The language is that there is social influence when it comes to making decisions about health. So can we develop an approach or in our interventions towards prevention of preeclampsia and management of preeclampsia? Can we have a package that looks at community so that we can talk about community involvement, creating awareness, something, engaging key people from the community so that they will know that it is not about women, it is about us, it's about the community. So that is the approach or the strategies that we want to propose.
I think Joyce will answer that because I know she's working on the spot and CEI is a big thing for them.
You saw me writing, and it's because this is a brilliant idea. We are currently working on the SPOT toolkit. So as part of SPOT Impacts, the previous session it was introduced, we're looking to develop together with many people, and this is an open invitation to all of you to be part of this process. So we want to create together a toolkit that will support health providers in risk communication, shared decision making, and ultimately help to improve the quality of care. What I wrote down there is we need to make sure the toolkit also provides materials to support community engagement, to support family engagement, because it's not just the woman, it's the woman in her community, and we all need to care.
Thank you so much, Joyce. So I guess I have the last word. I have only one question for you. So I believe in the power of one strongly. I have experience of the power of one, persistence. If I want something, I know I can't change what somebody else would do. I can only change what I can do. If it means I have to write an incident report every day, Until I get what I want, I'll pile up that paperwork. There's no need complaining about what is not in your control when you haven't done what is in your control. Too many of us look at the policymakers didn't do. So I just have one question for you. Will you make it count every time you see one woman? And make it count. Let it make a difference for that one woman. Can you do that? Thank you so much.
Dr. Lamte, I think I speak on behalf of everyone that this was a exceptionally inspirational meeting that was both inspirational through its content. We will download the guidelines. They will be disseminated through newsletter of Action on Preeclampsia Ghana. So if you're not a member of the newsletter, please do sign up. We'll also disseminate knowledge about the SPOT studies through the same newsletter. So please sign up to the newsletter and join more than 2,000 people who already signed up. I will ask that the website will be projected tomorrow, so it can be, so you know where to sign up. Your talk was inspirational. It was educational, and it was a testimony to the power of one.
Thank you so much. So we also run a website, aafrique.com, and if you go under news, you can read about prevention, read about my passion is diabetes. So you can read a lot of things there, which you can share also with your patients. So if you put Afrique, I speak a little French, so it's Afrique, A and then AFRIQUE.com under news. The rest of the things is not. But under news is where you can get the information for our patients. Thank you so much.
Final word is to Action on Preeclampsia Ghana, because I would like to share this citation to you, and I will read it out loud so everyone will hear it. This citation is in honor of Dr. Roberta Lemte for being a speaker at the 5th Preeclampsia Scientific Symposium held on 18th and 19th of May 2023 at the College of Physicians and Surgeons in Accra, Ghana. Motherhood means being 24/7 at the front lines of humanity. This was a quote by Marian Shriver. As a speaker, you have contributed to the education needed to make motherhood safer and thus improve maternal and child health for future generations. For this contribution, we as an advocacy organization are sincerely grateful. Accept our profound gratitude, Action on Preeclampsia Ghana.
Thank you so much. Totally, I don't know what to say, but sincerely, from the bottom of my heart, I'm so thankful. And I know all of you will make that difference so that 6 years down the line, I don't have to answer difficult questions.
A picture was taken, ordered by Korwa. You took a picture? Okay. Oh. Abana will come down for a picture. Request by Action on Preeclampsia Ghana. No. That's why. Thank you.
Thank you so much for this opportunity. You've been a wonderful audience, and please enjoy your lunch.
And with this, I know I'm between you and lunch. So with this, I would like to close the session, and I hope to see many of you tomorrow at 9 a.m., where we will continue with the second day of the 5th Scientific Symposium of Action on Preeclampsia Ghana. Thank you for joining us today.
Thank you so much. Thank you very much.